Hello, my name's Sophie Roberts, and I'm going to talk to you today about children with EDS and HSD and keeping them active. So I'm a podiatrist, MSK podiatrist, and I work in London in the UK. So firstly, we're going to talk a little bit about the role of podiatry, the pathologies and the things that we see in the pediatric and adolescent patient. We're going to talk about the podiatric management and some of the strategies that we can do to keep these children active. A little bit about kind of when to refer for podiatry and some of the kind of positive and negative effects of diagnosis or sort of complex treatment plans. And the thing to also kind of discuss or think about is, are we treating sort of symptoms or function or both? So we'll talk a little bit about that as we go through. It's often assumed we're born with a smaller version of the adult skeleton, but actually it takes years to adapt from kind of children that are obviously babies that are not walking up to kind of gait and everything that we achieve with that. During growth, the bones enlarge in 3 dimensions and become untwisted and derotated to put them in that sort of more advantageous position as the children develop. But the thing to remember is that bow leg, not knees, in-toeing and out-toeing gaits are common and can be normal lower limb variants. So it's good to sometimes reassure parents to not panic if there's a very out-toeing, in-toeing gait. So the sort of concepts that I talk about is that children are the ever-changing goalposts. So bone length and muscle bulk has to catch up. So as bone length increases, muscle length and strength has to catch up, and that can cause some inflexibilities along the way. And again, that's something that's sometimes confusing to think, oh, my child's hypermobile, but they're really inflexible, and how does that work? But sometimes, like, the posterior muscles are very tight, the hamstrings and the calf muscles, but actually the joints can, the knees can be quite hyperextending, and the ankles can be very kind of hypermobile. So the analogy I give, therefore, if we're trying to improve their structure and function, is that it's trying to put up a tent pole with tight guy ropes. It's hard to get it in the position if say the hamstrings or the calf muscles are very tight. And sometimes it's doing quite a bit of stretching and active stretching, and sometimes it's just kind of waiting for that kind of soft tissue to adapt. The other thing that's interesting, that's perhaps different with children versus adults, is the child's perception of pain and dysfunction, and the fact that maybe they don't know any difference. So sometimes you say, oh, does that hurt? And actually it may hurt, it's just that it's always kind of hurt. So they don't perhaps know any different. And the other thing is to think systemic or pathological if the biomechanical model is not adding up. So if they're getting kind of non-activity related pain, or they're getting very kind of symmetrical pain, or it could be that there's been a trauma, and therefore it could be more that something is torn or broken or fractured. So not always looking at the biomechanical model. So even though you see maybe poor biomechanics, then it could be that it's actually more something systemic or pathological going on. So we also talk about the kind of concept of tissue stress, and as children go through development, this can change. So individuals will have their own level of tolerance to the amount of tissue stress that can be withstood during walking, as well as activities of daily living. So some children are maybe more susceptible to this tissue stress, and also maybe does this change during development. So people's essential zone of optimal stress could, some children could be quite small in terms of they may find that actually just walking to school and doing PE just puts too much stress on their body, as opposed to just walking to school and not doing PE. Or it could be that they can do the kind of cycling and the kind of non-impact sports, but actually more the impact sports takes them into that kind of zone of stress. So this perhaps could be made worse by a more exaggerated response to foot pathology, perhaps their slightly higher perception of pain, There could be progression of deformity. So, for instance, the hallux valgus could get, as the toe deviates more, that could become more of a problem, but the more into that kind of zone of stress. They can have poor coping strategies, perhaps linked to their fatigue. And also, particularly when we're considering any surgery, they potentially could have, poor surgical candidates, and also rapid sort of deconditioning, perhaps after injury or during particularly fatigue times in their life. They could have rapid deconditioning, which could maybe make their kind of zone of the amount of tolerance to biomechanical stress more narrow. So I wanted to put this slide in here because ankle sprains are really common, and recurrent ankle sprains are quite often in sort of history taking when assessing a patient are very common. They can be kind of linked with a kind of a clumsy gait, as I said, very common in children with EDS. And if they are mismanaged and not rehabbed properly, they can actually lead to kind of over time a sort of adult acquired flat foot through these ligamentous disruption and a sort of change in essentially structure and then function of the feet. The most important thing to take away from this is the medial ankle strengthening is often overlooked in rehab, particularly with a kind of lateral ankle sprain. Often the peroneals are very rehabbed and not the kind of medial ankle. And to give that kind of stirrup of stability, the medial and lateral ankle strengthening is very important. And proprioception is needed, and potentially orthotic assessment if they've got poor foot position and function. But again, particularly the proprioception is quite poor in this sort of cohort of patients. So the proprioception training perhaps needs to be really pushed through that. Severs, which is probably the most common foot problem seen in podiatry in the kind of adolescent and sort of child age group. It is a calcaneal apophysitis, which essentially is an inflammation of the growth plate. So if you look in the bottom right hand corner there of you can see where the kind of pain and all the red is. That's the growth plate, and essentially it's where the Achilles attaches onto the heel, the calcaneus, and the tightness or the over pulling of the calf muscle and Achilles pulls that kind of tractional apophysitis, which is why is potentially is caused by a combination of calf inflexibility, poor shock absorption, and poor biomechanics, and very, very everted calcaneus may alter the mechanics on that of the pull of the Achilles on that kind of area of the foot. So it's not, the thing to remember, it's not an injury as such, so they can exercise within their pain. They're not going to make things worse per se, but certainly this is something we see a lot in podiatry, and can be managed well with footwear, insoles, of which is quite a strong kind of case for orthotics with severs, and cushioning shoes, cushioning heel cups, icing, and all of those. And it's just important just to, if it's not settling and responding to that, to rule out any sort of neural entrapment. I've just put that there. It's very rare, but just to have your differential diagnosis. So toe walkers, again, very common in this EDS and HSD cohort. It's an habitual walking pattern which usually ceases by 9. It can be deemed nature's way of strengthening, because it just to hold the foot up in that tiptoe position. As the child is growing and developing normally, toe walking on its own is unlikely to cause concern. But again, in this EDS HSD cohort, we want to check that it's not, with ankle sprains and pain, anterior knee pain, and also other things as well. Then we perhaps look for treating it. And essentially, from a proprioceptive viewpoint, it is smaller surface area for more proprioceptive input, which is why it's quite common, again, for this kind of cohort of patients to toe walk at some point in their development. And you also get that kind of adaptation as well. I want to talk a little bit about fatigue, which is, I feel, a precursor to treating or trying to keep these children with HSD and EDS active, because they are a major clinical manifestation in these patients. And certainly I found from my clinical practice that we can improve the fatigue with treating with orthotics, not only orthotics, obviously other things with physiotherapy and pacing and coping strategies and things like this, but perhaps by improving their pain, improving their biomechanical function, then perhaps the muscles are getting less fatigued, and it's helping towards improving that situation for them. As you know, the title of this presentation was Keeping Children Active. It's important to sort of just mention about the childhood obesity, which again can kind of sort of feed in, I think, to that fatigue, that kind of perhaps low tone, or that's and perhaps their pain and their inability to sort of do normal activities within school means that perhaps not, you know, burning so many calories, and then it sort of feeds into this childhood obesity, which is a problem. And it can be this vicious cycle with overweight children, as they should exercise to lose weight because of their weight, their feet hurt, they can't exercise. So actually that's where, you know, podiatry is really important, because if you can then get these patients to be more active, then that definitely helps. Interestingly, though, going back to the severs, there's no evidence to support weight is a risk factor in that severs. So just, you know, maybe to reassure some parents, but that's just a little kind of thing to mention there. So how does the management differ with the paediatric patient? We essentially strive to treat symptoms and consider the severity of the deformity. So, I mean, generally, me personally as a clinician, I tend to treat more the symptomatic patients, but certainly in some of the more, and I would probably say symptoms, PT potentially could be kind of put in with that, to consider the severity of the deformity as well. So very, very hypermobile ankles, you know, very pronated, collapsed foot position, low medial longitudinal arch. They need a lot more follow-up, because as I said back to that previous slide, they are the ever-changing goalpost, and so we do need to be following up perhaps children every 6 months to a year at least, or maybe longer as they're more adolescents. The feet do grow, and orthotics need to be made so that they essentially sort of grow into them and out of them, otherwise they're just going to be you know, growing out of them too quickly. Trying to make the exercise programs fun, so that they actually will do them and compliant. And sometimes, going back to that slide that I did at the beginning with, is that sometimes we just need to reassure parents that these are normal lower limb variants. So actually, you know, most children are a bit flat-footed till they're about 10, and you know, in-toeing is normal at around the age of 6, and out-toeing is normal at the age of kind of 14, but also looking for sort of asymmetrical findings, and just, you know, considering whether to over medicalize, and whether there's needing for investigations and, you know, more treatment, or whether you want to just kind of keep things simple. So you know, maybe, you know, we do think slightly differently, and the reason why I've put this lovely picture of this yacht in here is because I talk about finding the even keel for treatment. So it's about not over medicalizing, be proactive, treating the big problem first, and if the podiatry is the feet, you know, if it's the feet, then the podiatry is needed. So orthotics for the pediatric patient, as we've talked about that foot growth, they're perhaps different loading characteristics due to the changes in the rotational angular profiles. As I said, most children are flat-footed until that kind of sort of till about sort of 8 to 10. If they've got a very out-toeing gait, then externally rotated hip position, that can affect it. And, you know, some children may have had bad experiences with more rigid orthotics. That might make you want to try and get them on board with maybe something softer. And also the weight of the patient versus the rigidity of the device is important to look at, because if you've got a heavier patient, you might want slightly more rigid orthotic. If you've got a very, very light as a feather patient, then you may want something softer. Moving on to orthotics, Custom-made orthotics are made to a prescription and manufactured usually by a kind of laboratory or lab situation. There's different types of orthotics. There's kind of softer materials, harder materials. There's kind of cork, which is quite bendy, and polypropylene, which is a bit more stiff. They essentially are made up of a shell, which in that picture there is the kind of second from the top, the polypropylene. So that's the shell, which is molded to the foot, with the top cover, which is maybe more cushioning, and then external modifications in terms of maybe metatarsal pads or arch heights higher, heel raises for leg length differences. But the thing to always think, whether you're going to recommend an over-the-counter orthotic or whether a kind of technical customized orthotics, what are you trying to achieve? What are we trying to offload? Are we trying to cushion? Are we trying to change kinematics? Are we trying to change their zone of optimal stress by altering their foot position? So those are sorts of things we need to think about. So how orthoses work, they change alignment in some people, which is where you sort of see that knee stopping going in and the heels much more straighter. But some people, they don't change those alignments. We know that they do reduce pain, improve symptoms in some people, and some people they don't, and they don't find them comfortable. Essentially what they do in all people all the time is they change the kinetics, they change the kinematics. So essentially orthotics, any insole, whether it's custom made or over the counter, they apply force to the foot, which changes the kinematics, and they change the tissue at that interface. So how this kind of translates to orthotic prescription is the surface geometry that it influences. So the surface geometry would influence the function of the foot. So high arch heights, low arch heights, deep heel cups, wide orthotics. The low deformation is also about how you would change those forces. So whether you're wanting something with good shock absorption or want something really rigid to help sort of control some of that motion. And also the frictional characteristics of the orthotics is important to look at. So like and particularly with patients that are a bit more kind of sensory sensitive, we tend to use this kind of nice suede or soft kind of materials, EDAs, which gives that nice interface between maybe like a slightly more rigid shell and the foot. So orthotic solving problems with pediatric patients, we have to consider tolerance, whether they can tolerate what we're doing in terms of footwear fit, arch height, rigidity. Perhaps we may get them in trainers because the school shoe doesn't fit so well with the orthotics. Sometimes we just have to change tack. Sometimes they can't tolerate that material, and that's fine. You can trace something different. I've been prescribing orthotics for 23 years, and I'm still sometimes changing materials and I get it wrong. Obviously thinking about multidisciplinary approach, because it's not always enough just to put an orthotic in. You need the strength and conditioning, and you need the maybe some OT or exercise modification to allow them to kind of improve with their symptoms. And sometimes we just use temporary orthotics just to maybe get them over the injury, but it's maybe not something that they continue with throughout. So just mentioned juvenile hallux valgus, because it can be quite common in this cohort with a kind of deviation of the toe. I think the most important point at the bottom there is to delay surgery until skeletal maturity, and that in a way placates the parents, because you don't want to be having surgery until they have skeletal maturity, and then you sort of manage with orthotics and footwear until then. So a little bit on splints and braces. When we need to kind of apply a little bit more force up around the ankle, then the Ritchie brace is good, which is essentially a deep orthotic. That's on the right-hand side of the screen there, with the uprights. Again, with outgrowth, they have to be really quite unstable and severe for us to do Ritchie braces, just because of the cost of the braces and how quickly they can outgrow them. But we can use kind of maybe sort of air cast type splints and things. That X brace is really nice for kind of barefoot and gymnastics, because it gives a bit of support to the foot, a bit of proprioceptive input. The one in the middle at the bottom there, the Darko splint, can be used for the hallux valgus, just to maybe stem the tide, or and maybe that can be worn, you know, during watching television, and then toe props and light splints. Just finally, footwear. So that's an important part of their management. The knitted upper is really nice with the footwear now, because there's no less seams and it fits nicely from a proprioceptive point of view. It's important that the footwear is comfortable, that they like to wear the footwear that you're encouraging them to use, and sometimes that takes a bit of negotiation and compromise, both on the clinician's part and the patient's part. And also thinking about putting them in, you know, good school shoes that will give them good support, or you know, or maybe wearing trainers at school. So essentially, in summary, podiatrists are the key in the management of paediatric and adolescent patients with pathological lower limb biomechanical manifestations of EDS and HSD. I think we're a big piece of that puzzle. We need to manage factors that impair function, and try and, you know, help their symptoms and help with them in their daily life. And the other thing I'm just going to put in at the end, which is a little bit of caveat, is just to not treat normal children. So if they're just a bit hypermobile and not in pain, then, you know, not sort of over medicalize things, and just really consider what we're trying to achieve. Thank you very much.